I think it's the entire spectrum of antimicrobial stewardship, from the pharmacists involved and the antimicrobial stewardship team involved with formulary decisions. Which of these new pipeline drugs are going to go on an individual institution's formulary? It may be that they're not needed, so why put them on so that they might be used, overused, potentially overused, or used inappropriately? Maybe they're reserved and looked at as non-formula agents for some period of time, as long as their antibiogram supports the current drugs on the formulary. So that's one thing. Then next is, once these empiric antibiotics are prescribed, that de-escalation piece. We can improve that greatly. I don't think we're doing the kind of job we should be doing. With length of therapy, I think what evidence is telling us now that the length of therapy for antibiotic therapy may be shorter than we originally thought. And if we pursue research in that area and get shorter regimens that are effective, that'll decrease the potential development of resistance. That transitions of care, that's a huge place where we've got to get better. When we discharge patients from the hospital, we want to make sure they get the appropriate length of therapy. If we send them home with too long of length of therapy, then you're putting them at risk for side effects, community resistance, and Clostridium difficile diarrhea, which might occur in the community, and the person develops this severe case of diarrhea, and then they're readmitted to the hospital for dehydration and electrolyte imbalance. So there's a whole spectrum of ways that we can improve in the future. The other piece of that, we haven't talked about too much, but going back to Clostridium difficile, these are very serious infections. And if we can decrease the use of broad spectrum antibiotics, goes back to de-escalation, and decrease the use of certain types of antibiotics that are known to be, that are notorious for causing Clostridium difficile infections, like the fluoroquinolones. If we can do those two things and add that into our antimicrobial stewardship, we've done a lot of good for the patient.